Imposter syndrome is what we want to talk about, and I guess we all think we know what that is. Is it more complicated than just not feeling you are worthy of people's respect or admiration or whatever?
Yeah, it's a funny one really. It's not, so people might find it interesting to know it's not classified as an official disorder in any way. So there are lots of things and terms that people band around that are in the DSM that are given kind of diagnostic, so the Diagnostic and Statistical Manual of Mental Health or Mental Disorder, and that's almost, I don't want to say it's the Bible because there's a lot of issues with that particular book, but in terms of being given a diagnosis, typically something that is a diagnosis would be in there. It's not. There's an argument to put it in that book so it can be given to someone as a label. I have kind of some reticence around that, although it's recognised in terms of people experiencing the feeling of having that feeling of being an imposter. It's also known as imposter phenomenon, so there's kind of different ways of describing it, but essentially feeling like you are an imposter, or a typical imposter syndrome feeling, is when you feel you've achieved something, some kind of status, typically a career, where you've not got there on your own true merit, that it's luck or happenstance or even a mistake that you're there. And so you are feeling like you are actually an imposter in that place, potentially even in that role that you've undertaken as well.
Does it affect particular professions?
So when you look at the research, no, it's in all areas, although what's probably quite prominent in the research is it's usually people who are high achieving in some way, and typically it was really it was perceived as being more of an issue with high functioning women. I'm laughing when I say that, it's not funny at all. And also the kind of more contemporary research has shown that that's not really the case, that everybody has the potential to experience it. But it is very much associated with those roles that are tied to achievement or success. So career is often, like I said, the kind of lens through which it appears, if you like.
Can I just say, what does high functioning actually mean?
Yeah, I even grimaced when I said it because ignore I said that. High functioning, it means high achieving women.
Right.
So, they have a role of they're probably highly educated, and that's the other thing is that we see often there's a kind of a correlation in terms of highly educated women, that there's some kind of status or authority involved with the role that they're undertaking, so they feel that they need to maintain something in that particular role that they have. But like I said, it's not really, as I've said before, it's not just women. We know now it's everybody that will actually potentially feel like that sometimes.
While you've got that there, this is one of those things which I could never get my head around when I was doing A&P as a student. Obviously, the tendon runs a different course depending on the degree of flexion of the hip.
Yeah.
So when is it at most stretch? When is it at most risk?
So in adduction.
Yes.
So,
but adduction with flexed hip, or
adduction with flexion is the position where you're going to get most compression through. Yeah. So also in flexion, if you're in external rotation as well, because the gluteal minimus and medius in flexion are both internal rotators. Yeah. So if you have them in end of range external rotation, then you're going to have more compression as well. So but the tendons insert onto the greater trochanter. You've got, you probably can't see, but you have facets on the greater trochanter, so they insert in different areas. So you've got gluteus medius. For the front the anterior fibers insert on the lateral facet, and then you've got the minimus inserting anterior to that, and then the deep fibers or the posterior fibers insert on this superior posterior aspect of the facet. So you can actually sometimes through palpation think, oh, okay, well, it's more likely to be that that muscle part of the tendon, but it doesn't really matter. We're going to treat it the same, but it's just interesting to note that they insert in different areas.
Okay. What happens when you needle a trigger point?
Good question. Actually, what happens? You are putting a mechanical stimulus into muscle. Now the tip of the needle is clearly bigger than the muscle fiber. So What happens that you can see, if you get in the right spot, you see a sudden contraction of muscle. We call that a twitch, and the taut band relaxes, and that's what happens. Now the question is, how do you explain that? What actually goes on for that? There were thoughts, I remember in a panel debate with Robert Bennett from Oregon, does that needle poke a hole in the muscle and let the calcium leak out? Well, that seems to be a fantastical idea. I think more likely that needle is stimulating the distal nerve endings, and you're getting a nerve-induced contraction of muscle and a twitch. Then the question is, why does that muscle relax? And I don't think anybody has a good explanation for that yet.
Well, the course I run, and I'm running it again soon, is a behavioural change course. So it's a 5-week course on behaviour change interventions for healthcare practitioners.
So that's behavioural change in patients.
So it's about helping patients achieve change, which is ultimately getting them to adhere to anything you want them to adhere to.
Which is what we talked about when you were in here last time.
And giving you the psychological underpinnings to understand why someone might not do what you want them to do. So basic psychology, really. With that said, I work very hard on talking about integrated practice all the way through. So from the get-go, it's about you as a practitioner. So we cover all the things about the drama triangle, the gestalt parts of yourself, what you bring to the table in terms of your work.
The which parts of yourself?
Gestalt. So it's just like the parts that we have. So you will have 7-year-old Stephen that kind of comes along with you and maybe responds to things. I don't know, maybe Claire can tell me. Then
Claire would be glad if I were that mature, I think. Yeah. Okay.
But really, it's a set of tools to help you feel comfortable and confident when you're doing this work, really.
Right.
And in that, I talk about people setting up places for them to get together and share this and do this.
Yeah.
Because it is really important that they have that support. So there's definitely a place for people who are in a place where they're comfortable and confident in their career, where they maybe can do that. I think it's a great idea.
Yeah.
If you're going through sort of perimenopause, menopause, and your estrogen levels are reducing, that has an effect on tendon turnover, the collagen turnover. So if you've got risk factors as well, so there's a sort of a jigsaw puzzle of risk factors. The more risk factors you have, the more potential you have to develop this condition.
Okay, so talk us through a bit about women's health there, because I know we get quite a lot of interest in women's health because it is a major sort of problem area, I suppose. But menopause causes all sorts of changes. You just outlined something there. Does normal HRT offset those problems?
So there's a piece of research that shows HRT can really help with this problem, but only if the person's BMI is not considered to be high. In that population, it didn't have any impact, but yeah, HRT can definitely have an impact on the tendon health by restoring that balance. So yeah, that is a definite risk factor. If your patient has got issues with menopause, then it's well worth having a check with a GP to see if that could help. And often it does. So yeah, if it's the right treatment for that person, then it can have a real positive impact on tendon pain.
May I make one more comment on this, which I think is rather intriguing to me, and that is that after the first treatment, the patient comes back, and again, because if someone has had trigger point pain for a long time, one treatment is not going to get rid of it. If someone has had trigger point pain for a week or so, one treatment may get rid of it. But patients typically would come into our clinic with months and even years of trouble, and so they would be in therapy for maybe 6 weeks. Or someone we treated gets injured again and they come back in. So first of all, they ask for the needling because they know it will get them better. And then the peculiar thing is they will say to me, "Doc, your needle is off just a tad to the right." So they can tell, and then they'll tell me, "You didn't get the twitch." Or they'll tell me, "Doc, I feel you got it, it's done." So the idea that the twitch is painful momentarily doesn't keep people from coming back, and as a matter of fact, it is not only the sign to the clinician that they put the needle in the right spot, It's the sign to the patient that they're going to get better.